Hi, welcome to today's webinar on telemedicine reimbursement. My name is Anne, and you can't see me, but just a few quick housekeeping tips. We have slides in the handout section for both speakers, so you can download those if you're having any trouble with the sharing. This session will be recorded, and you'll be able to receive access to these recordings in 2 or 3 days. And we also have more webinars in this series coming up. So on Friday, there'll be one on patient-centered care. You can sign up for any or all of those webinars at vsee.com/webinars, and I'll have that link for you in your chat. So I'm going to go ahead and pass the time to Dr. Goldman, who is with ACCMA.
Thank you, Anne. Welcome to today's webinar sponsored by the Alameda Contra Costa Medical Association. In association with Global Health Impact Network.
Yes. We're having some feedback. So hold on just a moment. Let me make sure everyone is muted. Let me just go ahead and mute everyone who's not talking. Okay, go ahead and try again.
Okay. Sorry. Welcome to today's webinar sponsored by the Alameda Contra Costa Medical Association. Is that better?
Yes, that's perfect.
Okay. In association with Global Health Impact Network and VSee. This webinar series is being made available to multiple Bay Area medical associations across the Bay Area. My name is Dr. Gary Goldman. I'm a council member for the ACCMA, and I've been a practicing anesthesiologist at Alta Bates Summit Medical Center, a Sutter Health affiliate in the East Bay since 1989. I'm also a serial entrepreneur in the digital health space in continuing education, international health nurse staffing, and cloud-based healthcare provider data management and credentialing. I'm currently, and have been for the last 8 years, a Sutter Health physician informatics lead for EHR development, implementation, and optimization. I'm currently the founder and CEO of Global Health Impact Network, a clinician-driven collaborative network of clinical and digital health communities focused in the ecosystem of digital health innovation. We feel it's imperative that clinicians play an active role in what we believe is the precipice of a digital health revolution. The ACCMA is a professional association of physicians who are committed to addressing health issues of concern to patients and doctors in the East Bay. We provide a forum for physicians to come together to improve public health, the quality of the practice of medicine, and patients' access to care. This event is one example of among hundreds of activities that the ACCMA engages in every year to help physicians. These activities include political and public policy advocacy, things like holding local meetings with elected officials on healthcare legislation, regulatory compliance, things like ensuring network adequacy for covered California plans and helping members comply with Medicare reporting programs, and practice management assistance, things like presenting ongoing seminars and webinars on practice. This webinar is the third in a series of Getting Started in Telemedicine 101, and today's webinar will be discussing telemedicine reimbursement. And I'd like to introduce Uli Chettapalli. Dr. Chettapalli is a physician, researcher, author, and innovator. He is currently the president of Innovator MD, a healthcare innovation company. As a physician scientist, he is interested in technology-enabled care. He received the Pioneer Award for Innovation from Kaiser Permanente and Morris F. Collin Research Award from the Permanente Medical Group. His other roles include he's president-elect of the San Mateo County Medical Association, chairman, Society of Physician Entrepreneurs, the San Francisco Bay Area chapter, and he acts as an advisor, mentor, and investor at various healthcare startups. He's also the author of Punish the Machine, the Promise of Artificial Intelligence in Healthcare. Dr. Chetapalli will be the host for this seminar. Take it away, Yuli.
Great, thank you, Anne. And thank you, Gary, for that great introduction. I'm really excited to be here today with you. And we have two excellent guests that'll be speaking today. Let me introduce you to the first one. It is Anjali B. Dooley. She's a practicing healthcare attorney with 15+ years of expertise in physician issues, telemedicine, and practice management, legal representation, and compliance. Her current and past clients include nationwide companies in telepsychiatry, teledermatology, and teleurology, to name a few, both in direct-to-facility and direct-to-consumer markets. She currently also represents DTC consumer COVID-19 test manufacturers, distributors that are implementing telehealth as part of their platform for point-of-care readings. Anjali, welcome to the program.
Thank you. Thank you for the introduction. When you download the slides, you will have my information. So if any questions prior to or after the webinar, please feel free to contact me. I wanted to talk a little bit more about some physician issues and getting started in your medical practice with a telemedicine. The first thing that I recommend is making sure that you have your operational team together. There's a lot of things that you have to implement when you implement a telemedicine platform. Few of the things that I obviously want you to have your team together are your providers, your allied health workers, your nurse practitioners, your physician's assistants, and your front office staff. Understand the regulatory and compliance and legal issues that are unique to telemedicine. A lot of them obviously have been lifted currently, and so understanding that is more so important now than ever. And obviously, which Mary Jean will be talking about, having a financial billing expert ready who understands telemedicine billing. The next thing that I wanted to talk about is the types of telemedicine communications that you can bill for. Currently, you can bill for text messages, both asynchronous and synchronous, telephone conversations, and video. Everybody always talks about video as the telehealth method. However, the other two methods are very important as well. First of all, when we do talk about, one thing that I do want to talk about with video and implementing video into your office environment is, remember, this is just like you see a patient in your office. So have a dedicated space to see your patient. Also, do not hit the record button on the video as if you were, wanting to document later at a later date and you wanted to go back and visit the video. This is going to be a goldmine for personal injury attorneys or medical malpractice attorneys if they are able to capture the recording of the office visit. So I highly recommend do not record. There's asynchronous and synchronous, which asynchronous is called store and forward. So you send educational materials to your patients, or you send it over time and you're not communicating with them in real time, which is synchronous. And of course, the old way of communicating, which is telephone and giving advice over the phone. Currently, because of the pandemic, you are allowed to use Microsoft Skype, Apple FaceTime, WhatsApp, Facebook Messenger that is not a public facing, and Zoom Healthcare. Of course, these are you can use them now, but even if you're just implementing telemedicine into your practice, I would highly suggest using a HIPAA compliant platform. And here are a variety of HIPAA compliant platforms that you can use, which are Zoom, Google, VSee, DoxyMe, UpDocs. There's a lot. And the difference between HIPAA compliant and using FaceTime or Skype is that these corporations will sign a business associate agreement. And this is required when you're a covered entity, which most office practices are. What is a business associate agreement? It's an agreement between a covered entity, your office, and other vendors to safeguard personal protected health information. One of the other key components of implementing telehealth, and it has been debated, but get verbal documentation or verbal consent, sorry, and document that verbal consent when you're seeing your patient via telehealth. So for example, my mom is a family practice doc. She's doing telemedicine now. I have helped her implement it in her practice. She gets verbal consent from her or text message consent from her patient that I am seeing you via telehealth and you agree to that. So that is a great way, and she's documenting it in her chart or EHR. That is a great, just a practical guide on how to start a telemedicine visit. From a HIPAA standpoint, I just wanted to share some information is that during this pandemic, you can share, the HIPAA waivers have come into effect. They're 1135G waivers that have come into effect, and they are this, you can share information through the CDC and local state governments, or if you think other persons are at risk. Does not necessarily mean law enforcement unless it's an imminent threat to public or public safety, and you may, or society, and sometimes and family and friends. But a best practice is to keep minimum necessary disclosures. And take reasonable measures. Providers need to take, and covered entities need to take reasonable measures for HIPAA privacy and security, even in the wake of the pandemic, and even if you're implementing telemedicine. So although you can use FaceTime and Skype, I highly, again, recommend a HIPAA compliant platform. I also wanted to discuss standard of care for telemedicine visits. All of you are mostly aware what standard of care is, and it's how similarly qualified practitioners would have managed the patient's care under the same or similar circumstances. The medical malpractice plaintiff must establish this appropriate standard of care and demonstrate the standard of care has been breached. For telemedicine, the standard of care is same as an in-person visit. So that's just a reminder. Standard of care is also specialty driven, as we all know, local, and it's sometimes very local based. It is, again, same as an in-person visit. I recommend having your coding ready for what type of visits you want to do via telemedicine. For example, if you're a neurosurgeon, those visits are pre-op and post-op probably on essential surgeries that they can still perform. But define what you want what type of patients you would like to see via telemedicine, and talk to a billing expert and have those codes ready to go. So CMS came down with 80 new billing codes for telehealth. Just one of them is telephone calls. You can establish a new patient visit via telephone calls. Don't see that staying post-pandemic. I think that's going to be revisited. You can also cross state lines in many states without licensure in that particular state and bill for that care. So for example, if you're in Illinois and you go across the state in Missouri, where I'm at, and you see a patient in Missouri, you can bill for that care and actually establish new patient. But be aware that post-pandemic that you will have to have a licensure, more than likely in Missouri, to continuing seeing that patient. And there's going to be a host of issues on licensing. I would recommend looking at the Federation of State Medical Boards information on licensure waivers, but of course feel free to call your local counsel, your healthcare attorney, or feel free to contact me if you need. I also wanted to discuss scope of practice in telemedicine visits. The scope of practice, we understand, is specialty driven again, and those activities should be based on appropriate education, training, and experience. He or she is authorized to perform by virtue of professional license, registration, or certification. The takeaways from this is that make sure that you understand how many PAs and NPs you can collaborate with and still have those collaboration and supervision agreements. Again, some of these have been lifted temporarily, but we don't know what will be allowed to stay post-pandemic. When you're supervising and collaborating, often you can do that via telehealth as well. So you can have that collaboration by telecommunications, whether phone, video, or even text message. And I recommend do not practice outside of your scope during this time, or implementing your telemedicine program into your practice. So some of the practical guidance I have is, suppose you have, you're using text. You are able to download that real-time text communication and input it into your EHR. Talk to your EHR. It may already have a strategic partner that is a HIPAA-compliant vendor platform for telehealth communication. And more than anything, I recommend document. Be prepared to implement that telemedicine. Contact your RCM, your revenue cycle and billing expert, as well as get some expert advice from your vendors and other people that have implemented telemedicine before. And with that, I think I'm handing it off to Mary Jean. Oh, and if you need to contact me, here's my contact information. Feel free. I'm managing attorney in my own law firm. So thank you.
Thank you, Anjali. We're excited to have Mary Jean Sage here as our presenter. Mary Jean Sage has many years of experience working with physicians and other healthcare professionals across the U.S. MJ's lecture engagements have included the AMA and many state and local medical associations, specialty societies, and medical group management associations. She is recognized for her expertise in coding, billing, healthcare compliance, and Medicare audit response. Her presentations are known for practical information she conveys in a clear and concise style. Please welcome Mary Jean. It's all yours.
Thank you, Dr. Chetapalli. So today I wanted to go over some of the codes we'll use with telemedicine, go through some of the challenges that we're having right now during this pandemic especially, and get you ready to not only use telemedicine now, but hopefully once we're out of the pandemic and the rules change a little bit, you'll still find that telemedicine is a good option for you. So certainly the challenges are many today. The biggest challenge is there's no payer consistency in the rules, which codes they allow, how do they want you to report the place of service, what modifiers, if any, do you use. The payer policies are literally changing overnight. We get new things all the time. Yesterday, Cigna put out some new information, for instance. The one thing I am finding is that more and more of our commercial plans are now going towards mirroring what Medicare is doing, at least during this pandemic. It may all change at the end of the pandemic, however. There are certainly multiple lists of allowed codes out there via telehealth. Again, during this emergency time, we are finding more of the commercial plans are mirroring what Medicare is allowing. There are certainly has been some confusion between what are really telehealth visits, the difference between that and an online digital E&M service. Do telephone visits count? Which of course they do during this pandemic. As Anjali said, probably not going to count after the pandemic is over. And then how do we use computer technology-based services, which is a Medicare concept. Also, one of your challenges now, as Anjali also said, please check with your malpractice carrier before you start to do telemedicine. There are a number of issues that you'll want to check and make sure that you're doing correctly, consent certainly being one of them. So just briefly, there is actually, let's define telehealth versus telemedicine. We are using this term interchangeably by many during this period, and not everybody refers to each of the concepts in the same manner. So telemedicine is really the practice of medicine using technology of some kind to deliver care at a distance. When the physician is in one location, using an infrastructure to deliver the care, and the patient is at a distant site. Telehealth broadly refers to all kinds of electrical or electronic and telecommunication technologies and services used to provide non-clinical care and services at a distance. Again, we see these terms used interchangeably. Just make sure you're familiar with each of your payers and what kinds of services fall under each of these. We don't want you to think you're doing telemedicine and going to be paid at that and then find out that, for instance, telephones don't really account. So in our environment today, which includes Medicare, telemedicine is when the practitioner is in their office or at another site and the patient is at home, or the patient could be in the hospital because telemedicine is covered there as well, or could be in a nursing facility. Our practitioners use the CPT or HCPCS code to report whatever the service is that they do. For Medicare, they want us now to use a place of service where you usually provide that service, if it's in the office, if it's an inpatient hospital environment, or wherever. Some other payers will want you to use a place of service 02, which is our telemedicine site of service. Also, we differ as to whether we use a modifier or not. Medicare wants us to under the waiver, use the modifier 95, telling us that it was a telemedicine service used by accepted technology. Some other health plans aren't requiring the 95 modifier. They'll accept it, but it's not required. So we've had these 101 codes approximately that have been considered telehealth service codes. And just recently, again, as Anjali mentioned, we've added 85 additional codes under the pandemic waiver to add some additional services. Some of the additional services that were added are therapy services. What I do want to caution you about is, even though there are therapy services there, some of our payers don't consider our therapists to be providers that can provide telehealth service. That's the case with Medicare. Also, there are all these other additional services that we have on the slide here that are considered telehealth services, and commercial payers cover them, as well as Medicare is actually is covering them as well. So we need to document our services, just as we've mentioned before, and you document like you would for a patient if you were seeing them face-to-face. So for our evaluation and management services, if counseling documents the visit, then yes, of course, use your time to select your level of service. Remember, though, that you're only going to count the practitioner time, although it could be the practitioner time getting ready for the service if they had to look at reports. Excuse me. So for our established patients, we're going to do 2 out of the 3 of our key components, which are history, exam, medical decision making. For new patients, it would require all 3 components, unless, again, you use time as the option for selecting your level of service. So as far as the exam can be observational, but that will probably limit your level of service because there's only so many things that we can do observational. But I would encourage you actually to listen to Dr. Feldman's presentation from earlier this week, because he and Dr. Chatapalli had a nice discussion about what elements of a physical exam you can really do via a telemedicine. Now, there is a little bit of a catch to this that has come about because of the March 30th interim rule that was published after the waiver was approved. In this interim rule, they've added a section, Section W, that's entitled Level Service for Office Outpatient E&M Visits when Furnished via Medicare Telehealth. It's a very brief section, but it starts by discussing the upcoming changes we're anticipating in 2021 for our office outpatient codes 99202 to 99215. And remember, these anticipated rules are going to allow the practitioner to make their selection of E&M service based upon the total time for that day or the medical decision making. You don't have to utilize history and physical exam to determine your level of service. So the time spent includes non-face-to-face time, again, that the practitioner spends and does not need to be dominated by counseling. So currently, under the interim rule, CMS is using different time thresholds for selecting this array of services based on time during the health emergency. So they're not the same time as we have currently in the CPT book. But basically, they are removing any requirement for history and or physical exam during the time of emergency. So since this is a fairly new concept, we will post on the ACCMA's COVID-19 resource page a more detailed description of what you need to document and how you need to document. Certainly, you always want to document the consent that's required for the patient also. We will build these telemedicine services using place of service 11 if it's in the office, or whatever the usual place of service is. If it's in a nursing facility, if it's a inpatient hospital service, whatever the usual place of service. Do not use place of service 02, use 11 instead. This, of course, will go in field 24B of your CMS 1500 form or whatever your electronic equivalent is when you submit your claims electronically. Your location, which is in field 32 of that same form, will be your office location. There was some instruction right after the interim rule was passed that if physicians were providing telemedicine services from home, they needed to enroll their home address as an additional location with Medicare. That is not so at this point, because we've gone to using place of service, the usual place of service. You're always going to use your office location in field 32. Again, one of the things that you want to remember is the requirement for consent. It does vary by state, but in California, part of our business and professional code clearly spells out that you need to have the consent of the patient, and you want to make sure that you do document that consent as part of your encounter for the day. A couple of things going on with our commercial payers and telemedicine, and hopefully, while some of these will change at the end of the pandemic, we will see telemedicine paid in a better fashion and more frequently than we have in the past. So I think we will be making a step forward at that point. So the CPT Appendix P does have a list of services that CPT considers to be performed via telemedicine. That is not necessarily the list that everybody else uses. It's not the same for CMS and Medicare. They have their own list. Your commercial payers likely have their own list as well. So that's one of the things that you want to make sure that you check on when you call or go online and access the guidelines for telemedicine for your commercial payers. You need to make sure that we do check every payer's website, read the emails that are coming through. We are all getting emails daily from the commercial plans about the changes in their rules during this emergency time. You do want to make a list of those payers, develop a grid for yourself with the important information. And I've given you an example here of one of those grids. Along with, you want to make sure that you document where you go for the information, because you'll want to access that frequently and make sure that they haven't made any changes. There has been quite a question about cost sharing. They're under the interim rule from CMS. They have said that providers may waive cost sharing, but they don't have to, except for a couple of exclusions that have to do with COVID-19. So it is up to the provider whether they want to waive that cost sharing or not. Aetna has waived their cost sharing if the patient is accessing an in-network provider for them. Now, briefly, let's divert from telemedicine for just a second and talk about the virtual check-in, because some of the payers have encompassed this virtual check-in in their scope of telemedicine services. Remember, the virtual check-in is that quick 5-minute telephone call, or you can use other telecommunications, but it can be telephone only when you decide whether the patient needs to come in or not. We would bill this with not a CPT code, but with a HCPCS code. It's G2012. These are for established patients only. You wouldn't do this for a new patient. They are not considered telehealth services. You would bill it with your place of service office, just as always. It can be audio only, doesn't have to be video. It doesn't pay really well, so I would encourage you, if you have the capability to do audio video and do a true telemedicine service for your E&M visit, that would be a much better scenario for you. Remote monitoring is also one of those things that are sometimes confused or interpreted to be telemedicine, and it really isn't. The remote monitoring is when the patient sends you a quick picture of the rash on their arm, for instance, and said, do you think I need to come in? What the HCPCS code itself describes this service as is you have some kind of picture that comes into you. The provider has to interpret what it is, and then there needs to be follow-up with the patient within a day of having received that. The follow-up could be the clinical staff as far as that goes. Again, it's a service that's only for established patients. And if you could, once again, if you have the capability to do a quick telemedicine visit for that, that will be a much better scenario for you. And then lastly, sometimes we see our e-visits, which are our email visits, confused as being part of telemedicine as well. So we have new CPT codes for 2020 and a couple of new HCPCS codes also for this particular service. It's when the patient initiates an email into the office, the provider then emails back to the patient. It's not a face-to-face video encounter at all. It is generally through your patient portal, but it is email as well. These are kind of confusing to document. There are some specific 7-day rules that are attributed to each of them. They are, for the most part, time basis. Again, there's a lot of documenting and a lot of rules to keep in mind when doing these, and they don't actually really pay very well also. So again, if you have the ability, the infrastructure to do the E&M telemedicine service, that's going to be a much better way for you to communicate and see your patients. So in wrapping up, I just want to kind of tag on to what Anjali was saying at the end of her talk about being prepared in the practice itself. You want this to be a good experience for both the practice and the patient. So get your team together, and one of the things that you want to do is look at your appointment schedule and determine how you're going to schedule these telemedicine visits. And then also what you're going to do with the patient at the time that you schedule them, because remember, we have to obtain consent. And when you schedule the appointment with the patient, that's a good time to talk to them about what the telemedicine visit really is and to gain their consent. But just always make sure that that consent is documented at that time as well. Also remember that these telemedicine services probably don't have the cost sharing waived with them. So this is the time that you also want to collect the co-payments for your patients, which of course you'll want to do online. But this is a great time at the time that you do schedule that. And then you do want to plan out your visits, whether you want to have a certain times during the day that you do these visits, or whether you want to have days of the week that you want to do these, or plan out how you want to really incorporate these telemedicine visits into your practice. So the last 2 slides here, I just gave you a few tips on things that you can do to make it a positive experience for both you and for your patient. Again, Dr. Feldman covered a number of these things yesterday or the day before when he talked about from a malpractice standpoint and eliminating some of the risk and that. And making sure that the patients really come around and look at these telemedicine services as viable services themselves. So you want to make sure you have good technology in place so that everybody hears well, everybody sees well. You want to make sure that you're in a setting that's professional looking. You want to make sure that you understand that depending upon what the patient is using at their end, and that there might be a little lag in audio. So before you just start talking and talking and talking, you want to maybe just pause briefly, let the patient catch up. You want to make sure that you're in a setting that really looks like your office and is real professional. So like Anjali, I'm happy to answer questions if you have some that aren't answered today. Email actually works really well for me, and I would be happy to help, but I'm going to turn it back over to Dr. Chetapalli, and I believe we're going to have some questions and answers.
Thank you, Mary Jean, for that detailed explanations. Yes, we do have a question and answer session right now, and I'm getting a lot of questions. So you can use the question box to type in your questions so that one of our 2 panelists can answer those questions. Okay, Larry writes, how detailed does the verbal consent have to be? Do you have an example of one where we can use, and does it have to be signed? And another question about, consent is, what if a physician-to-physician consultation is being made via telemedicine or telehealth? And does the patient have to consent for that? Maybe Anjali, can you answer that?
Yeah, so on the verbal consent, I would document it just as if you were getting, usually you have a form in your office that has an informed consent form. And so possibly just read off that form. That's a good way to start. And no, the patient does not have to sign it as of now. You just have to document that you have, read the form, the patient agrees, and at that point, put that in your documentation and chart. The second question what was it, Yuli?
Physician to physician consultation. Does the patient have to consent?
Yeah, usually a consult in that sense is not have to be consent. A patient doesn't have to consent to that at that point, because you're getting probably an expertise, and that would just be as if you were talking to a expert from, you need a cardiology consult or something like that. So the patient does not have to consent to that necessarily. Not every instance, but when you believe that you think that you need to recommend this patient going to a cardiologist, for example, then say, I recommend that you go to a cardiologist and get that consent that I'm going to share information with the cardiologist. But if you're just asking a question generally, that without patient name or information, then at that point I would not no need for consent from that patient.
Thank you. The next question is about HIPAA regulations. Can a patient waive their right to privacy to protect the physician? Can they say, I don't care about HIPAA, go ahead and you can disclose my information?
Sure, they can do that, but right now HIPAA waivers are in place, so you could share information as reasonable as it should be. But most patients will, you can put that as part of your getting informed consent, that this patient has allowed me to share information with their mom, their dad, their significant other, their partner, whatever, and share that information. But again, I would look at the HIPAA privacy rules and what waivers are in place, still be reasonable, and if in doubt, contact your lawyer.
Thank you. The next question is about recording. Now, you mentioned that the physician or the provider should not be recording the sessions. What if the patient is recording the sessions and then can use it against the physician, or even just make it public?
Well, that is a risk by using a non-HIPAA compliant platform. So there's that reason for using a HIPAA compliant platform, because most of those platforms have ways where the patient, it is not, the patient can't record the office visit. So there are ways
Not directly.
directly. I mean, if they're going to do it, there are bad actors, they're going to do it. They're going to have another phone right there and they're going to have it recording. You can't stop that from happening. That is the difference between an in-person office visit and telehealth, or telemedicine. So bad actors are bad actors. You can't stop that. But in general, from a platform standpoint, there are reasons to use telemedicine approved HIPAA platforms.
Great. I guess this question may be for Mary Jean. Jeffrey asks, I'm a pediatrician, not a psychiatrist, and not a mental health professional, but I do behavioral work, including cognitive behavioral therapy. Which codes would you suggest I use?
Well, that's difficult to answer without exactly knowing what it is that he's doing. But a lot of the behavioral health codes are now on the list as covered telemedicine services. So it's likely that he could certainly do those, but to actually give him an actual CPT code that could be used, I would need to see a description of what it is that he's doing to help him pick the exact or the correct code. But for right now, a lot of the behavioral health testing and other services are on the list of covered telehealth medicine. However, that would be a coverage issue with some of our commercial plans as well. So you'd want to check with your common commercial plans, give them a list of CPT codes that you typically bill, and make sure that they are covered. Because one of the other things that we have to consider is sometimes our commercial health plans contract out behavioral health services. So we as PCP providers can't provide those services for that patient, for that health plan. So you'd want to check that as well.
Great. Santi Rao, okay, Santi asks, is there an implicit or explicit HIPAA agreement with basic subscription service for one of these telehealth services, like Zoom or something like that? Is there a HIPAA agreement in there?
What do you mean, like a business associate agreement? Is that the question, or?
I guess the caller is asking, is HIPAA included in the service, when you pick a service?
Right. So if it's a HIPAA compliant platform, what that means is that company will sign a business associate agreement, meaning they are saying we're guaranteeing safeguarding the protected health information. I think that's the answer. Yeah, that's the question. Okay.
You got it. Noel asks, can a staff person or a nurse do the auscultation part of the exam and document as such? In other words, let's say you have a clinic and the clinic has your nurse there, but you are at home, and can the nurse listen to the lungs and say, we can document that in the telehealth part?
So is the nurse also doing telehealth from her house, you're saying?
No. I think it's the doctor doing that.
But the nurse is at the clinic, so he's supervising.
He's at the clinic.
Yeah, so if there's a collaborative agreement or supervision agreement between the nurse and the PA, or the physician and the PA, or the collaborative agreement between the physician and the nurse, of course, they can document that visit and bill for that.
Yeah. I guess this question is for Mary Jean. The place of service, David writes, is still confusing. Can it be home office? I'm considering taking on new work in telemedicine via third-party companies and doing this from home. Yeah.
So remember, your place of service is always where the patient is. Okay. So right now, most everybody is having you use the place of service wherever you typically do this. Okay. If things change after the emergency here, and we do expect that some of them will, typically we would report any telemedicine service with place of service 02. Then you do have to report your location on your claim form for certainly all federal plans, and most commercial plans require that as well. So that will be an issue also with the health plan, whether and again, that's typically where the patient is, but for telemedicine, we would still have it be whatever your location is. So that's it's hard to answer that specifically now and know that this is what it will be this time next year and all the years thereafter. But if you typically practice from your home address because you do only telemedicine and that's where you do that, then generally that will be your location. You do have to be a little careful with Medicare enrollment though, because Medicare doesn't always allow us to enroll using a home address as our practice site. Now that will typically change as we use telemedicine more, and we see that practitioners are doing telemedicine. They don't have an office. They typically will be doing a telemedicine from home. But there are generally in the enrollment documents from Medicare, that's usually spelled out very clearly. And so you'd want to make sure that you look at those as well. Right now, you can certainly do it from home. You're still going to list the location, whatever your typical location is. Kind of a convoluted answer, I'm sorry, where we don't have, you know, something more specific right now.
Thank you. Thank you, Mary Jean. I think this may be related, but I'm not sure. Rachel asks, why should we use POS 11 instead of POS 2 or 02?
When or why?
Why?
Why? Because
Yeah.
that's what Medicare and the health plans tell us to do right now.
Okay.
And that's changed because originally when the waiver was adopted, we were telling everybody to use 02. Medicare was advocating that you had to use if you were going to do it from home, you, the practitioner, had to enroll. They set up those hotlines for quick enrollment. And then when the interim rule was actually printed and we could all read through it, and they did make some changes, they decided it's going to be 11. You're going to report where you typically are. So right now, the reason we're doing it is that's what we're told to do.
I see. Good, thank you. Noel asks, how often can you do a virtual check-in with a patient? Is weekly okay?
Well, this is a new service for Medicare in 2020. I don't believe that we have any what we call medically unlikely edits or unbelievable edits on that. But, you know, there is, if you read the definition of that service, it does say that they can't be, that you can't, the call can't result in a next day visit or as soon as possible visit. So there are some restrictions there, but that's actually a good question, and maybe we can post that on the website. But I'm not aware of any medically unlikely edits right now. Are you, Anjali? I don't think there are any.
No, and I think it depends on, honestly, the payer, because I've been talking to some physicians on that as well. And they said, well, UHS or Optum allows it, but like, have you heard anything from Aetna? You know, so I don't know, really. I think that's something that needs to be looked at.
Well, and that was one of the changes that Cigna just issued or produced this week, is they will start to cover that service, but I didn't see a limitation as to how often you can do it, but maybe we can do a little investigation into that.
Okay.
Sure. The next question is from Mike. He asks, can you bill for an e-visit and a telemedicine visit on the same day?
Probably not, because, and again, it would depend upon the payer, but Medicare only allows you to do one, they only pay for one E&M service on a day, and those are both considered E&M services. So I would say probably not. So what you should do, though, is if you do both of those, encompass what you did in both of those and then bill the most comprehensive service.
Great. Couple of related questions coming from Rodrigo and Lynette. Can you talk about inpatient or hospital telehealth consultations?
So,
well, go ahead, Anjali.
No, so when what do you mean by that? Like how to do one direct to facility? Is that the question?
I guess it's more on the billing side. Can you do it? Will the insurance pay? That kind of stuff.
Okay.
Yeah, I mean, from my previous clients who were direct to facility, yes, payers do pay for the inpatient telehealth, depending on what type of specialty. Obviously, right now they don't want doctors to come in if they don't have to, right? So depending on what type of visit it is, telepsychiatry, for example, inpatient is definitely rounding. All sorts of things are done. And from a billing standpoint, Mary Jean is more of an expert on the inpatient billing and what are the codes, but there are definitely for skilled nursing facilities, for long-term care facilities, direct to facility billing is available and is routinely done.
Mary Jean, can you add?
Yeah, and I would agree absolutely with what Anjali was saying. Inpatient services, inpatient subsequent care, as well as nursing facilities, that all those codes are on the list of covered services right now. Typically, Medicare does pay for some inpatient telemedicine services and certainly some consultation services anyway. But right now, all of those CPT codes are on the accepted list to be provided by telemedicine.
Also, one of the things that I have often seen recently over the last few years are virtual medical directors of skilled nursing facilities, especially in rural areas. So that has been a typical way of having a medical director at places that would typically not have the availability of one.
Great. Thank you. The next question is from Dana. I guess this is the question of co-share payment. If the insurance plan may waive a client's co-share payment, it's up to the physician or clinician to determine if she would waive the fee. Is that true?
Yes, for the most part, because what even CMS has said is that the providers may waive their co-payment if they want to. And I believe Aetna is saying at this time, and look at the grid that we used on the thing, that it's up to the provider. They may waive it if they want to. However, they don't have to. Now, you don't want to get that confused with what CMS has said at this point is there is no patient sharing for COVID-19 testing, but that's CMS's provision all the time anyway. There's never any patient sharing for laboratory services. And they have said that hospitals could waive the patient cost sharing for other services if they elect to or if they choose to, but it's not mandatory that the provider or supplier do that. And definitely during the crisis or the emergency here is if you're seeing the patient for something that's not COVID-19 related, then generally the cost sharing is not waived at all.
Thank you. The next question is from Irina, and she asks, what's the difference between phone visits and video visits as far as billing is concerned? Is there a time spent that needs to be documented?
Well, I'll start, and I'm going to have Mary Jean end on this particular question. There is definitely, I think, difference between a video visit and a telephone visit in many ways. She really spoke about this and definitely in the E&M services. But let's say it's a new patient. A telephone visit I personally do not think, and legally do not think that is a best practice to have a new patient visit and document that as a with a phone, just over the phone. I think it should be via video. So from a billing standpoint, I think if in the long run, let's just say post-pandemic, that telephone visits are also in sync with e-visits, the price, the payment for that is going to be lowered and lowered over time. So there's going to be more patients that physicians have to see. So it's going to be, it's just going to be a cyclical nightmare, I think, that's going to end up post-pandemic. But I'm going to let Mary Jean talk about this a little bit more. She's more of an expert in that anyway.
Well, no, and I agree with you, Anjali. So the phone visits right now are being covered. Typically, they're a non-covered service, certainly for Medicare and a lot of the commercial plans as well. So if you did a phone visit, you would be billing the patient for that. And they are time-based. Now that they are covering them, the reimbursement is very low for those, and you have to consider what you can really do with a phone visit versus, you know, a compliant platform and do the e-visit. We were, I believe, all quite surprised when CMS came through and said, all right, we're lifting the non-covered status of telephone visits at this point, and we will start to pay for them. Now, I do understand if you have patients who don't have the capability of doing video, you don't have another choice. Your phone visit is what you're going to have to do. And I guess you could look at it as some reimbursement is better than no reimbursement as far as that goes. But they are weighted lower. Therefore, they are paid lower, and they are, for the most part, they're considered E&M services, but they are time-based.
Okay. Thank you very much. I think that was the last answer, to the last question. We're out of time, but if you have any specific questions, you can always email one of our speakers. Thank you, Anjali Dooley and Mary Jean Sage, for that great talk and very informative. Thank you.
Thank you.
Bye-bye.
Thank you and goodbye. Stay safe, everybody.
Thank you.